Hi, good afternoon, everyone. My name is Ellen Vera, and I'm with our Provider Outreach and Education team here at WPS, Government Health Administrators. So we are going to be talking about global surgery modifiers today, and this is part 2 of 2. In the original one that we did back on May 9th, we went into a lot of detail on the global surgery concept itself and how Medicare determines that, the pricing for that, et cetera, and provided you with some resources. For this presentation today, we're really going to go into some of those exceptions to global surgery and the different modifiers that you'll use to show that. This is a collaborative event. What you have listed on the bottom of your slide is all of the different logos from the 7 different Medicare administrative contractors. We all work together to put this presentation together. We wanted to make a consistent message across all of the contractors so that everyone is getting the same information. The next slide that we have is just our disclaimer slide. This tells you that the information that you have here today is correct as of today. But Medicare rules change and they can change often. So you want to make sure that you're signed up for our listserv, and you can do that on our website just at the bottom left-hand side of the screen by entering your email address. You also want to sign up for the CMS listserv. They send out at least one on Thursdays called MLN Connects, and it has a lot of different information, changes that they have made, etc. Any responses to questions are going to be based simply on the information that you've provided to us, but we just want to remind you that the Medicare rules and regulations and your documentation will determine any final coverage decisions. CMS does prohibit recording of the presentation for profit-making purposes. So if you are recording, we would ask that you stop doing that. Here's what we're going to be talking about today. We want you to have a good understanding of the global surgery concept. We want to identify individual modifiers and how you determine which modifier is appropriate for the situation that you have. And then specifically, we're going to talk about the LT, RT, and 50 modifiers. We're going to talk about split care, which is the 54, 55 modifiers, and then modifiers for additional surgeries during that global period, which is the 58, 78, and 79. So let's talk about the global surgery concept. Well, what CMS does with this is it pays a single fee that includes everything that goes on with that surgery, all of the required services, both during the surgery, after the surgery, and for major procedures the day before the surgery. And so it's one fee that encompasses everything that's going on. So the purpose of that is going to be to include everything there together. Surgical procedures performed by the surgeon, if that's part of that global surgery package, that fee is going to be paid back to the surgeon or to members of the same group with the same specialty. Medicare views members of the same group with the same specialty as though they were the same person, and therefore Medicare is going to reimburse them or pay for that surgery as if it was one provider. So what are some of the included services under the global surgery package or global surgery concept? Well, preoperative visits include visits after the decision for surgery is made. So what we mean by that is if you decide you're going to do a surgery on March 15th and you do that surgery on March 30th, a visit on March 30th or March 29th is going to be considered part of that global surgery package, and therefore Medicare is not going to make payment for that. For major procedures, it is the visit on the day before of the surgery. Major procedures are the 90-day global period. Minor procedures are the 0 or 10-day period, and visits on the day of the surgery are going to be included. Interoperative services include everything that kind of goes along with that, with the surgery itself. So that's going to be removal of ports, insertion of staples, all of that kind of stuff. The postoperative period begins the day after the surgical procedure. So when we're talking a 0-day surgical procedure, it's only the day of the surgery. So it says 0, but it really means 1, just that day of the surgery. For a 10-day postoperative period, it really means 11 days, the day of the surgery, and then 10 days following. And then for the 90 days global service, it really means 92 days. It's the day before the procedure, the day of the procedure, and then 90 days after. So any follow-up visits that are related to that recovery from the surgery are going to be part of that global surgery package, and you would not be billing for those separately. That also includes, you can see here, post-surgical pain management by the surgeon, where the surgeon is having to maybe prescribe some pain medications, maybe doing physical therapy, ordering physical therapy for the patient, etc. Now, if the surgeon is transferring pain management to somebody else, and Medicare does see this sometimes, there has to be a medical reason why that other physician is responsible for that pain management as opposed to the surgeon being responsible for that. So that's going to be all based in your documentation. And then treatment for complications can be separately payable, and we'll talk about that in a little bit, but it basically means you have to take the patient back to the OR in order to treat those complications. Otherwise, it is simply part of the postoperative care. And then other services that you may be doing for that patient during that postoperative time, and you can see just a few of them listed here, are also part of that single payment for that surgery. Suture removals, bedside procedures, removals of ports and drains, that type of thing. So what are some excluded services? Well, the first one listed there, the initial evaluation resulting in a decision for a major surgery. Now, what we mean by that really is that we need to do this surgery now. If you decide that you're going to do surgery for a patient and your documentation shows this patient needs a hip replacement on March 15th, and you are scheduling that surgery for April 15th, you made that decision for surgery on March 15th. Your documentation is going to support that. So if you see the patient the day before or the day of that hip replacement, that's not an excluded service. It's not the decision for surgery. That was really made back in March. So you want your documentation to support whatever it is that you're doing. Physician services who are not the surgeon or a member of the same group with the same specialty, the global surgery concept doesn't apply. So if your cardiologist in your practice is the one doing the surgery, your family practitioner is treating the patient for something else, they don't need to append any modifiers to their service. It's not part of that global surgery package. Visits that are unrelated to the surgery diagnosis. You do a hip replacement, and then you're going to provide an E&M service for the patient's diabetes. Well, those two are not related. The diabetes is not a result of that surgery. Therefore, you can bill for that separately. Diagnostic tests or procedures where you're doing x-rays, you're doing EKGs, something along those lines, those are not part of that global surgery concept, and therefore it doesn't apply to this, and then you don't have to append any modifiers. And then the last one, clearly distinct surgical procedures. You do a hip replacement, and then you have to do a shoulder repair. Well, those are clearly distinct services, and we're going to show you when we get into those modifiers, which modifier you would append to that. Additional excluded, post-operative complications, which require a return trip to the operating room. That's going to be modifier 78, and we'll talk about that when we get to that section. Unrelated critical care services. You have a patient, let's say they had an auto accident, something like that, and your surgeon has done a repair of the broken leg, but at the same time they have concussions, they can't breathe, whatever the situation is. Those E&M services can also be payable separately. And then the last two really goes back to your documentation. Treatment for the underlying condition or an added course of treatment. What we mean by this is you're doing the hip replacement because the patient has arthritis. Well, if your visit today is for the arthritis, then that can be a separately payable service. In the webinar that we did on May 9th, it went into all of the different modifiers that you can append to your evaluation and management services. An added course of treatment means that you're changing something in that evaluation and management service from what you had determined to begin with. You decided to do a hip replacement. You find that that hip replacement is not working the way that you want it to for that condition. And so now you're going to do something else in addition to that. Documentation, again, is going to be key for that. And then the last one, if you did an organ transplant for the patient and you are now monitoring that that patient's immunosuppressive therapy for that, that can be payable separately. That also is going to more than likely be an evaluation and management service, and you'll want to listen to the encore of that May 9th presentation to see the different E&M modifiers that would apply to that. Global surgery settings. Surgery, of course, can be provided in all kinds of different settings. The first two there, ambulatory surgical center and hospital, that's going to be billing for the facility charges. And so the global surgery concept that we're talking about here today really does not apply. This is more the professional fees as opposed to the facility fee. Surgery can also be done in an intensive care unit or critical care unit, depending on the patient's condition and what you need to do. And then, of course, surgical procedures can also be done within the physician's office. Now, the next thing that we're going to talk about are the modifiers that go along with this. Okay, so what you're seeing up on my screen right now is our modifier page. And there are several different ways that you can get to this. If you go into the WPS website, you choose the state in the contract. There is a section over on the right-hand side of the page called Quick Links, and modifiers are listed there. You can click on that and come back to this page. You can go into our topic center under claims, the guides and resources, scroll down to modifiers, and still come into this page. So I want to show you just a couple of things on this page. Okay, the first modifiers that we're going to talk about are going to be the bilateral modifiers right here. So you can see there's modifier 50, LT, and RT, and we'll show you the information within the slides. I'm also going to scroll down. Hopefully I can not pass it up this time. And see here we have a whole section on surgery modifiers. Now we're not going to talk about all of these. Some of these are E&M modifiers, which we talked about during that first presentation. Some of them are specific to different situations and procedures. but all of the modifiers are listed here for you, so you can take a look at those. All right, so we're now back into our presentation. We're going to talk about modifiers LT, RT, and 50. Modifiers LT and RT and 50 are identifying where you have done the surgery. LT and RT are left and right. So you're identifying, I did this on the left side of the body or the right side of the body. And obviously, in order to use one of these modifiers, there has to be a left and a right. For an example, your liver doesn't have a left and a right. Your arms have a left and a right. And the other thing with these two modifiers is that you always want to use them when it's appropriate. Otherwise, it can cause a denial. One of the reasons that we see for denials quite often is a provider will bill a left knee replacement or bill a left leg amputation, etc., but they don't include that LT modifier. So then 3 or 4 years down the road, they do a right knee replacement or they have to amputate the right leg. Medicare is going to deny that service because we don't know which side it is. So when you're doing a single service like this, always use those LT and RTs. You can also use your anatomical modifiers to specifically identify where this happened. So if you identify left the LT modifier on that first knee replacement, and then the RT on the second knee replacement, Medicare will not deny that. So when do we use these? Well, the LT and the RT can be used with diagnostic and therapeutic services. And it's used for unilateral. You're doing just one of them at a time. You don't want to be using the LT and RT when you're performing a bilateral procedure. You want to use modifier 50 if that's appropriate at that time. Modifier 50 identifies that this is a bilateral procedure during the same operative session. So you're doing both the right and the left knee replacement at the same time. So you would use a modifier 50 rather than using the LT and the RT modifier. You only want to be using it when the procedure code description will allow you to do that. So for an example, if your procedure code description says it is a bilateral service, then you don't want to use modifier 50 because you're telling us that you did 4. So for an example, if you're doing a service that states it's bilateral and you use the modifier 50, we're going to want to see documentation because most people don't have 4 sides of something, unless the patient is really having some problems. Now, in addition to that, when you're reporting modifier 50, you want to use it as a single line item. So you're going to have your procedure code, your modifier 50, and then you'll have one unit of service. And that will tell us, hey, I did this twice by using that 50 modifier, and then Medicare will be able to pay appropriately for that. Okay, now we're on the cms.gov website. And what we want to look at is when does this bilateral apply? So what I did when I went into the website, and you can see here, I just did a search under physician fee schedule. And this top thing that comes up is a lookup tool. So you can look at just the individual procedure code that you're thinking about, trying to determine whether it's a bilateral, whether it is not. This document right here under the downloads is a description of all of the different fields on that fee schedule. So it goes through each one of them, describes all of the different indicators, etc. So now we're going to begin our search. And of course, we have to accept the CPT license agreement. And then when we scroll down, we can enter information. So we can use a particular year. If we have a range of procedure codes we want to use, if there's modifiers that apply, etc. We're going to go into the national payment amount, and the procedure code I'm entering is just the 66984, which is a cataract surgery. So now it's going to search for the fees, and I'm going to scroll down, and this is the information that it shows. You can see the procedure code over here, a short description, and then it gives you a lot of additional information. I'm going to scroll sideways. And then this is the information we want to be looking at for our procedure code itself. The first thing that we have here is that this procedure code is a 90-day post-op time. So we know that any additional services we're providing during that 90 days, the day before, day of, and 90 day after, then we need to look and see, is it related to the surgery, part of the global surgery concept? The next information we have right here is the percentages that Medicare applies for the preoperative care, the intraoperative care, and then the postoperative care. You can see here it's 10, 70, and 20. In a lot of cases, it's 10, 80, and 10. It kind of just depends on the procedure code. Then you have a multiple surgery indicator here. And again, in that document I showed you, that PDF, it will give you all of the information there as to what that means. And it goes to how Medicare prices the service. And then here we have our bilateral indicator. And so we have a bilateral indicator of 1. What is a bilateral indicator of 1? Well, what it tells you here is that the 150% payment adjustment is going to apply. So let's talk about what that means. When Medicare is making payment for a surgery, we have a fee schedule amount. When you're looking at the bilateral, it's how is Medicare going to price that bilateral procedure code? So under the 0, we're simply going to price based on the units that you submit. Under the 1, we're going to take the Medicare fee schedule amount for that surgery, and then our allowed amount is going to be 150% of that fee schedule amount, because you're doing 2 services with that modifier 50. When you submit that, you'll have the procedure code, modifier 50, and 1 unit of service. Under the 2, the 150% payment does not apply. An example of this is going to be your diagnostic, like x-rays, radiology. Medicare will simply pay for 2 of those and pay in full for 2. And then 9, the bilateral policy doesn't apply. Generally speaking, that's going to be on evaluation and management services, other things that have nothing to do with the surgical pricing. So what are some problems with using modifier 50? Well, modifier 50 is being used on codes where bilateral is already in the code description. So if the code description says bilateral, the pricing for that has already been determined for 2 of whatever it is that you're doing. Midline organs go back to the liver. You don't have a right and left liver, you only have one. And then the bottom one, this one's a little trickier, different areas on the same side of the body. So if you're doing a lesion removal, for an example, on the patient's left forearm and a lesion removal on the patient's left shoulder, you would not use modifier 50 for that. There are some additional modifiers that we'll talk about in a second that can help you identify that that's the situation that you have. So what are some resolutions with that? Well, look at your code description to begin with. Does it state it's bilateral, or does it state it's only unilateral? Generally speaking, if the code descriptor states unilateral, then there's going to be a bilateral procedure code. We've talked about the liver, bladder, etc. that's listed here. You don't want to, of course, append modifier 50 on that. And then remember to look at your bilateral surgery indicators, because you only want to append that on indicator 1, not the additional indicators that are listed on your screen. So now let's talk about medically unlikely edits and bilateral surgeries. Medically unlikely edits really identify what Medicare has determined are the normal and usual units of service for that particular procedure code. You want to report modifier 50 when it's a bilateral surgery and it's appropriate in order to avoid some of those medically unlikely edits. There is a special edition CMS document that's listed there for you. There is also the Medicare National Correct Coding Initiative policy manual that's listed there for you. All right, so what we did in order to get to this page is under the search function on the CMS website, I simply put in NCCI. And so this brings me back to all of the information about the NCCI edits. Over here on the left-hand side of your screen, you can see the medically unlikely edits pages, and we'll go to those pages in just a second. Also on this page, you have add-on codes. Your add-on codes are going to be your procedure codes that are not going to have global days attached to them, because it's simply in each additional to whatever the primary code is. So this could have an XXX, Y's, or Z's, something along those lines. So if you want to know whether your procedure code is considered an add-on, here's where you can go. So we're going to go into the medically unlikely edits. And when we scroll down here a little bit, you can see the actual tables. We want to go into the practitioner table, and you'll notice that this is a zipped file. So I already have it open. And so what I have up here for you is what this zipped file is going to look like. Now, what I want to draw your attention to is a couple of things. Number one, here's a listing of all of your procedure codes, and this is just the first page. You can do a Control F in order to find your individual procedure code. The next column that we have is the actual MUEs. This is what Medicare will allow on a date of service or on a single line of a claim. You can see on this page, these are all ones. The next thing is the adjudication indicator. So you can see here, we've got a 2. This is a policy. It's the code description or CPT instructions that require that. And then we have a data service edit clinical, which means that the NCCI contractors, they have determined that 1 is the appropriate response for that particular procedure code. So for the details, here's kind of what I showed you over on that Excel file. The other thing I want to let you know about is that these are updated quarterly. So if there are usual services that you do within your office, you do want to make sure that you're checking this at least quarterly to make sure that nothing has changed on this. That next bullet point, the MUE tables don't address modifiers, such as the RT or the LT or the anatomical modifiers. And then we've given you the adjudicator or the adjustment indicator. The line, the 1 means that it may require a modifier. Again, these are probably going to be your anatomical. The 2 means that there isn't a modifier that will allow above the listed MUE. And then for 3, you would have to request an appeal. Now, let me give you just a piece of advice here. If you're submitting units of service above what that MUE is listed on that website, you want to split those lines. Otherwise, Medicare is going to deny everything that's on there. So split those lines. Your units of service are going to be the MUE on the first line. The second line is going to be your additional units, and then of course your pricing for that. Use the narrative function either on a paper claim or your electronic claim to let Medicare know that that's why you have split this into two lines. And then when you appeal that, you'll need to provide information as to why it's medically necessary for you to have performed additional units above what the MUE is actually listing. So now we're going to switch gears here and we're going to go into the split care modifiers. Well, these are modifiers 54 and 55. And, I showed you over on our website, you want to scroll down to the surgical modifiers in order to find that. So let's define modifier 54. And what this basically says is that I did the surgery, but I'm relinquishing all or part of the post-operative care to somebody else. You can have this in cataracts where you're going from the MD or the DO back to the ophthalmologist, back to the optometrist who can bill Medicare. So you're not doing the entire global surgery package. This is a pricing modifier. Using this modifier will pay you for that intraoperative and that preoperative percentages. It won't pay for the postoperative. So using modifier 54 then, you use the surgical procedure code and the surgery date of service, and then you're going to, I use the 54. You want to tell us in, again, that narrative field when you gave up care. So you did the surgery on the 15th. This was at an ASC. You turned care over to that provider, to another provider on the 15th. So in that narrative field, then you'll tell us you relinquished care on the 14th, and then the other provider took over care on the 15th. You don't want to be using this modifier if the patient is under that surgeon's care for the full postoperative period, either the 10 or the 90 days. You don't want to use it if your indicator is 0 because it's just today. And then it doesn't apply when an ASC is billing, and it doesn't apply when an assistant at surgeon is billing. The situation could apply, but they don't use the modifiers. Modifier 59 is for that second physician. What they're telling us when they're appending this modifier is that they have taken over postoperative care. There's been an agreement between the two practitioners. The one person is doing the surgery. I'm going to be the one doing the postoperative care management. A lot of times you can run into that situation when you're doing a surgery at like a major hospital in a major city, and then the patient is going back to their primary care physician in their more rural area. But so let's talk about the correct use. Again, you have to have 10 or 90-day post-op. When you're billing the services to us, you have to report the date of the surgery, and you have to use the same procedure code as what the surgeon used. And then you'll append modifier 55. You'll include in item 19 or that narrative field to tell us, I assumed care on March 15th. I relinquished care on May 27th, whatever the 90 days would be. And then include the number of days for which you are responsible, not the number of days that you saw them, but the number of days for which you're responsible for their postoperative care. The next bullet just reminds you that you can't bill for that postoperative care until you provide that postoperative care. So the surgeon transferred care to you on the 15th. You don't see the patient until the 30th. Once you see them on the 30th, then you can bill surgery date of service, surgery procedure code, modifier 55. If you don't see them until after the postoperative period, then you won't bill this way. You'll simply bill your evaluation and management services. And then always submit your units of service as one. So what are some incorrect uses? Well, one of the big reasons we see for denials is that the surgeon did not include the 54. The second physician included the 55. Well, Medicare now has to deny that service. We have to do further investigation into that to see if the surgeon billed incorrectly, if this provider billed incorrectly. Really, it's just better to use those modifiers appropriately to begin with. Has to be billed on a surgical procedure. You're not going to include this on an E&M service. And again, for an ASC, they're not going to bill this modifier, and an assistant at surgery is not going to bill this. Now, in your third bullet point there, and our document says incorrect use, we're missing some language on that third bullet. Billed on a surgical procedure other than the surgical procedure that's part of this, or other than the original date of service. So you can add that in. So what are the errors on here? Well, we've talked about the incorrect date. You have to have the assumed and relinquished dates because we divide that post-operative time by the number of days, and then the percentage that applies to that, we pay for each of those days. Well, if we don't know when you assumed or relinquished care, we don't know how many days to pay for. There's no documented transfer agreement. If the surgeon is not determining that he or she is transferring care, the other doctor is simply seeing the patient, then modifier 54 and 55 would not be used. It's only when that formal transfer of care occurs. And then denials, of course, if you're not using the modifiers correctly. So let's give an example here. So we have one doctor who is performing a cataract surgery, and he's transferring care to an ophthalmologist on October 3rd. The ophthalmologist then is relinquishing care on January 1st. So how would we do that? Well, on this screen, it shows you we're going to use the date of service for the surgery, the procedure code, that's a cataract surgery removal, and modifier 54. We're going to have one unit of service. The surgeon does not need to place anything in item 19 because he's relinquishing right after the surgical procedure. The other doctor, though, the way he bills is going to be that same date of the surgery, same procedure code with modifier 55. Quantity is still going to be 1. He's going to indicate in item 19 or the narrative function when he assumed care and when he relinquished care. So you can see here there's 89 days. So Medicare would do the math on that, take the percentage of the fee schedule amount for the surgery, divide that by 90. This is a 90-day procedure, and then we would pay for 89 days. Now you'll also notice here that the surgery was 10/2, the assumed post-op is 10/3. Those two dates cannot be the same because the surgeon is responsible for the date of the surgery, and then it is the post-operative care that the other person is taking over. Now, on this particular slide, and I'm not going to go through the math on this, but this shows you how the calculations would be done in this situation of a modifier 54 and 55. The next example that we have is also a fairly common example, especially for cataract surgery. The surgeon performs the surgery, and he's going to keep that patient and be responsible for that follow-up care through October 12th. At that point, then, he's going to transfer that patient to Dr. Pierce in our example. And then it tells you Dr. Pierce also relinquished care on the 1st. So how is this billed to us? Well, the surgeon is going to have two lines. Your date of service is still the date of the surgery, but your surgeon is going to bill with the surgery procedure code and modifier 54 on one line, 1 unit of service, and then the same surgery procedure code and modifier 55 on the second line, again with 1 unit of service. In item 19, or your narrative field on your electronic claim, he's going to tell us he assumed care on the 2nd, because that's when the surgery was, and he relinquished care on the 12th. Then on the other side of your slide is how that co-managing physician or the physician to whom the care is being transferred, how they're going to bill. Same date of service, same surgery procedure code, modifier 55, and then they're going to indicate in the narrative field, item 19 or narrative on your electronic claim, that they assumed that care on the 13th, and the dates have to be consecutive. They can't be the same date. Medicare will deny that second claim. And then also he identifies when they relinquished that care. The next slide just walks you through the math on both the surgeon's claim for the 54 part and the surgeon's claim for the 55, and then walks you through the reimbursement for that second physician in using that 55 modifier. The next modifiers that we have then are 58, 78, and 79. Modifier 58 is a staged or related procedure by the same physician, again, during that post-operative period. So what we mean by that is a couple of things, okay? You have planned the additional procedures at the time you planned the first one. So when you do those additional procedures, you're going to tell us that by using that 58 modifier. 58 can also be used for related procedures other than modifier 78 situation, which we'll talk about in a second. This could be a more extensive procedure than the original. It could be a therapeutic following a diagnostic procedure. And then it's important to note that a new post-operative period begins when you use this modifier, which means you're going to get the pre, intra, and post-operative payment. So what are some of the incorrect uses? Well, again, an ASC is not going to use it. The assistant at surgery is not going to use it. You're not going to use it with zeros or X's because there isn't a post-operative period. You're not going to use it for unrelated because there's another modifier for that. And you're not going to report it for a treatment of complication requiring a return trip to the operating room because there's another modifier for that. So what are some examples? Well, we have one here. The physician performed a removal of a breast lesion. Physician documents they would perform a mastectomy following the biopsy results. Well, they got the biopsy results back, and yes, they need to perform a mastectomy. They did that. They're within the global period of the original procedure, so they're going to append modifier 58. That tells us that it's staged or related. It does not reduce payment or affect payment other than to allow payment. The second example is kind of similar. The patient has a breast biopsy done. A week later, the surgeon performs a mastectomy. Again, we've done a diagnostic. Now we're doing a therapeutic. We're also doing a more extensive procedure when we're doing the mastectomy. So adding modifier 58 to that would be the appropriate modifier. You want to make sure that that subsequent procedure is within the global period of the original one. If it's not, then you don't need a modifier at all. If it's planned or staged or related, that's when you use that 58. Modifier 58 can also apply when it is a related but unplanned or more extensive than the original. Now, the next modifier that we're going to talk about confuses people, and we understand that. You can see the definition there: unplanned return to the operating room by the physician following initial procedure for related procedures during the postoperative period. Medicare doesn't use that same definition. For Medicare reasons, you have to have a return to the operating room for a treatment of a complication. And how you want to kind of look at that is, would I be doing this service if I had not done the previous ones? Patient has a dehiscence of their surgical site. Well, that's a complication, but they wouldn't be having that if they had not had the original surgery. So that's how you can kind of help to identify those situations where a modifier 78 applies. The other thing with this is that it is the treatment for complications requiring a return trip to the operating room. So in the example that I gave, if you can fix that dehiscence of the suture line in the office, it's not a payable service because you did not have to go back to the operating room to treat that complication. And because you didn't, that's part of the global surgery reimbursement for that procedure code. You can also, if you have to take the patient back to the operating room, it could be the same procedure code. And then the bottom sentence there, a new postoperative period does not begin. Modifier 78 is a payment modifier, which means we pay the intraoperative percentage only. We don't pay the preoperative or the postoperative. Those are being reimbursed from the original surgery that was performed. What's on this slide is what Medicare defines as an operating room, an actual operating room at a hospital, either inpatient or outpatient, cardiac cath suite, endoscopic suite, etc. It does not include a patient's room on the floor in the hospital, a minor treatment room within your office, the recovery room. It also doesn't include an intensive care unit unless the patient was so critical and what you had to do was so immediate you could not get them to an OR, in which case documentation will have to support that. Incorrect uses are outside of the global period, obviously, when you don't make a return trip to the OR to treat complications. And again, that all goes back to your documentation. You want to review that original surgery procedure for the global days, either the 10 or 90, in order to even look at using any of these other modifiers. Documentation has to support what the complication is and where did you correct. The next modifier that we have is modifier 79. This is an unrelated procedure performed during that postoperative period. So how is modifier 79 appropriate? Well, this is when you're doing an unrelated procedure during the postoperative of another one. So you did a hip replacement on the 15th. You also did repair of a torn rotator cuff on the 22nd of the next month. Those are not related. Therefore, you deserve, and Medicare will pay you for that second surgery when using modifier 79. You'll also notice on here that a new postoperative period begins, which means you'll get the preoperative, intraoperative, and postoperative payment. And your documentation has to support that these are unrelated. Incorrect uses, obviously reporting on related procedures, reporting on those with those X modifiers, reporting when your surgery is outside of the global period or when another physician actually performs it. Keep in mind, same group, same specialty equals the same person for Medicare. So how do you resolve those? Well, you want to look at your documentation, look at CPT instructions. What does it say about whether or not the two services are related? Look at your global days. Before that original procedure, are you still within that time frame or are you out of that time frame? So we have some examples here. Patient's right big toe amputated because of an infection. Within the post-op period, the surgeon goes in and has to amputate the patient's right little toe because of something falling on it. Well, you want to use your anatomical modifiers, but you also want to use Modifier 79. Modifier 79 tells Medicare this is not related and therefore should be paid separately. Another example here, the physician performs surgery on a lump in the patient's forearm, turns out to be a benign cyst. Within that post-op period, the same patient returns and has a fibroma removed by that same physician. They're not related. Therefore, as long as they're within the same global period as that first surgery, then you can use Modifier 79. Some key takeaways for here. You want to make sure you're looking at the terminology of your procedure code, the CPT terminology for that, to determine whether or not Modifier 50 is appropriate. You also want to be looking at that physician fee schedule to see whether or not that service can be done as a bilateral procedure. You want to use the LTs and RTs whenever you can for those unilateral services. It really just kind of saves you grief in the long run, especially in talking about hip replacements, knee replacements. That's the two more common ones we've seen because those can be years apart. If you're doing split care, you need to use that narrative function in order to tell us the assumed and relinquished dates. If we don't have those dates in there, then Medicare cannot pay for it. Modifier 58 is for staged or related procedures. 78 is for return trip to the operating room for the treatment of complications. And 79 begins a new post-operative period. The next thing that we have up on your slide is a QR code for a survey for this presentation today. You can use your smart device, your phone, laptop, whatever, in order to kind of take a picture of that and go take the survey. We also have a link for you listed on this slide. Your responses to the survey are very important to us. Number one, it's part of our reporting to CMS. Number two, it allows us to look at how we have done the presentation and so that it's the very best it can be for you. If you think we did absolutely fantastic, then please tell us that. If there are ways you think we could improve, then please tell us that. In the middle of your slide, you can see the highlighted area and that little blue area. Once you exit the webinar from WebEx, this page is going to come up. It is not spam. It is simply going to take you to a page where you can actually take the survey. And then the last slide that we have is just some of the references that we have looked at for today. So that concludes the presentation that we have for you today. We hope you have an absolute wonderful rest of your day. Thank you for your attendance.